So why don't we have folks on the phone introduce themselves?
Hi, this is Terry. I am from the Reinhardt Clinic, and I am the panel manager here.
Hi, Terry.
Hi, this is Brian Frank. I'm a family medicine doctor at Richmond, OHSU.
Hi, Brian. Hi, Brian.
This is Treva. I'm also from OHSU Richmond.
Hi, Treva. Linda, I don't know if you're able to speak up. It looks like we have Linda Larson from Rogue on the line as well. So I will just mention you. It looks like you might not have the phone piece set up, but welcome.
And Linda, oh yes, you said good morning. Good morning, Linda. And let's just please put in the chat since you're the one person I think who's doing the computer audio, let us know if there are any issues with that.
Okay, so with that,
and I think Teresa Perry.
She introduced herself.
Oh, she did. I'm so sorry.
Yes, that's okay. I'm here. And I just want to say that Katie Boner, who is our enrollment navigator here at Reinhardt Clinic, will be with me in just a few minutes.
Okay, great.
Okay.
All right. And we might have some additional folks joining along the way. And like Victoria mentioned, we'll be sure to share everything out to folks that weren't able to join us today.
So I'm going to be passing the computer along to, oh, actually, first we're going to.
So, yes. So we've talked a little bit about today's agenda, but here it is up on a slide. We have Lynn Knox from the Oregon Food Bank, who will be presenting on her work both in terms of food insecurity screening and some really accessible intervention approaches that many of you might have heard of, but perhaps some of you have not. And then Brooke Nicholls from One Community Health is going to be highlighting their fantastic work on food insecurity. We're really excited to have you share with our folks today. And as we mentioned, you will get an opportunity to ask questions along the way, so feel free to speak up, and we will create another opportunity at the end of their presentations for questions. And then we will do a quick check-in on what we have coming up with the Food Insecurity Collaborative over the next few months as we plan our pilot work for January and February. And Denise, welcome. We see that you're on as well. So I think with that, we can dive right into our first presenter, who is Lynn Knox.
Oh, nope. Oh,
shoot.
So we've got a very short video here that looks at the issues of food insecurity and health as they are intertwined.
Oh, that's good. And it's rolling. Did you know that 48 million Americans children are food insecure? This means they lack consistent access to enough nutritious food for an active, healthy life. Food insecurity and persistent hunger can have long-term effects on a person's health. At Feeding America, we are working to ensure everyone has access to this healthy life. Can everyone hear, or are you? Should we share this with you separately?
No, I'm really unable to hear what's happening.
Okay, let me pause this then.
Okay.
Yeah, I think that video, maybe we will send it separately in follow-up for you all to watch. It seems like it's both choppy and there's some issues with sound. So sorry about that, but we'll be sure to send it in follow-up for those of you that are interested.
Okay, now how can we get past it all? Okay,
right there.
There. Great. Okay, well, sorry about that, folks. what I like about that little 1-minute video that might be valuable working with your staff in the future is that it really does look at how food insecurity and poor health reinforce each other, and how the poor eating habits of the poor come about, and it tries to address some of the myths that really blame the victim often. And I want to reiterate what Victoria said, that during this presentation, we didn't know, quite how many people were going to be involved, and there's quite a range of experience here. And some of you are already really engaged in some work on food insecurity, and some of you may or may not be. And so interrupt me. Let's make it useful for you rather than just a static webinar, please. But one of the things I wanted to talk about first is that there's a lot of talk about different kinds of screenings and the importance of doing them to kind of maintain your integrity and your quality as a health clinic. But there's a lot of unexpected things that in the over 200 sites across the state that are screening, we have seen that really happen when you do start screening for food insecurity. It totally changes the awareness, the understanding of the staff in the clinic about the nutritional situation of their patients. All of a sudden, it's in their face, and it can't be denied, and it increases the commitment, the interest of staff in doing something to address the problem. I can't tell you how many times we've implemented screening, and a month or two later, the staff are coming back and saying, what more can we do? We've got to do more, whereas they were barely willing to implement the screening in the first place. The other thing that I think is really underestimated and not realized in a lot of situations is how critical the information about the food security situation of the patient is for the provider visit the day that they're screened, or every day that the provider sees that patient. Because if they don't have that critical piece of information, they may diagnose things with similar symptoms to food insecurity as, say, depression or ADHD or a variety of other things that have some similar symptoms, and they may proceed to treat that condition with drugs or other interventions that don't deal with a real problem or that complicate things. So it's just a critical piece of information to have available with the exam of the patient. And it triggers that provider to think in ways that she or he was not trained to think. Our medical schools and nursing schools have not, over time, emphasized nutrition very much and given the information that providers really do need about nutrition. But having that diagnosis of food insecurity is like a red flag to that provider saying, oh, well, maybe we need to address this before we go someplace else. And then the patients respond very, very well to this. There sometimes has been a concern among staff that patients will feel their privacy's been invaded. Why are you asking this? It's none of your business. It has nothing to do with my health. But in fact, overwhelmingly, implementation with patients goes smoothly. They don't object to being asked about this issue. And then sometimes we get real appreciation. I've done some limited survey work in clinics that have been screening for a while, and always one of the consistent questions is with the patients, do you think that it makes sense for your provider to be asking you about your challenges obtaining healthy food? And overwhelmingly the answer is yes, this makes a lot of sense. So I think that you'll find it creates more closeness with the patients because it gives them the sense that you know that their lives are stressful and complicated outside the office. And then, very importantly, it targets limited resources in the clinic setting to those that are most in need and the ones that are ready to act. If they've acknowledged the challenges with food insecurity, they're much more likely to act upon improving them than if someone had not. The basics of implementing food insecurity screening are very simple. You can do it as a standalone. We always suggest doing it in writing. We get a 30% higher level of food insecurity revealed when it's asked in writing than when it's asked by a clinician or another clinic staff person, and it takes less time. So it's a win-win, either maybe as part of the check-in process or when they're put into the exam room. Whatever works for your clinic, it can be incorporated into something electronic that the patient's given to respond to. I have some places where they've programmed it into a tablet. Many places it's in writing on a checklist that they just quickly respond to. There are all kinds of approaches, but then it needs to get to that provider they're seeing that day so that they have the information for diagnosis and treatment. And then the most important step is the follow-up. We provide you with a one-page list of your county's food and nutrition education resources in multiple languages so that you can put this into your electronic health record system, give it a dot phrase where you can retrieve it as part of the after-visit summary, and then have someone from the clinic, be it staff, trained volunteer, or an intern, sit down with that patient who screened positive for food insecurity that day and review it with them. It doesn't need to be a long process because you stop at the very first resource that is new to that patient. People can't handle more than one new resource a day, and you don't have time to deal with it. But if you stop at that new resource, go into the information that's available there on the resource list because you're sitting at a computer with them and can go into a website where you can find, be it an application for SNAP that the two of you can fill out in a couple of minutes and then submit, or be it a list of all of the food pantries that are available in the area. They'll be mapped so that you can find out where they are and what's convenient for that patient. Whatever the new resource is, it's one new thing that you connect them to, give them the ability to access it as easily as possible right away. And then it's also possible that you may want to incorporate these 2 screening questions into something that you're already doing. If you're using the Prepare tool, I believe that it's in there. If you have some other broader social determinants assessment, like I know Mosaic does, they've integrated the 2 questions into there. There are a variety of ways to go about this, but we do encourage you to do the screening frequently. The once a year or twice a year just isn't enough to track what needs to be tracked, because our economics are so volatile these days that a family within a 6-week period can become seriously food insecure because seasonal work has totally dried up, or because somebody lost a job, or the family broke up because of domestic violence, or thousands of other reasons that can plunge families who were teetering on the edge into total crisis. And then the food insecurity starts showing up because the kids are acting out in school, and the mom is sunk into depression, and you've got all kinds of things that are spinning out of control where food insecurity is a key problem. So it doesn't matter how you do it, part of a general assessment or a totally separate 2-question item, but it needs to be done as frequently as you can implement it into your system. We again provide the 2 nationally validated questions in multiple languages. We provide a 1-page county resource list that you can use with patients. We can help you and others can with how to fit it into your electronic health record system. And then we do advise, if it's feasible within your staffing or volunteers, to follow up with that patient a few weeks later to see if they were able to connect to that new resource, or to prod them just a little bit more about doing so. These are the ICD-10 codes that are being used to track the food insecurity screening, and it has been integrated both into OCHA, EPIC, and the broader EPIC system now, so that working with your own IT folks or your representatives from OCHA or EPIC, you can figure out where to find it and how to make use of it. If you can see this, this is the way it is integrated into mainstream EPIC now in their 2015 release. These are the 2 nationally validated questions. A response of a 1 or a 2 on either one of these questions means that they are food insecure. Again, any response on question A or B of a 1 or 2 means they're food insecure. This is the example of a 1-page resource list that we give you to incorporate into your EHR. Again, they're available for each county, and it's maintained behind the scenes. That way you don't have to worry about, you know, where's my brochure, or is this up to date, because all of these websites are maintained behind the scenes and kept up to date on a regular basis. In almost every case, we've tried to also provide a phone number so that people can utilize that. But particularly for those patients who aren't computer literate, we do really emphasize that sitting down with them after the screening and after their clinician visit is critical. We've set up systems where a whole term of a nursing school program is dedicated to work with a specific clinic, and they have a routine schedule of interns that does the follow-up with patients. We have other settings where they have a group of volunteers that have been trained to do this and are on a regular schedule to be available in the clinic to work with the food insecure patients, or community health workers, or care coordinators, or social workers. There are a wide range of staff that are appropriate to spend those few minutes with a patient who is food insecure, connecting them to the new resources so that it really happens. We believe very strongly that immediate reinforcement of the importance of that connection to new resources is critical. I'm glad to provide training for any volunteers, nursing interns, staff that might be given that task to review the resource list with patients. There's a variety of strategies about how to deal with people that are reluctant to use new resources or that feel uncomfortable with it and think that, oh, this is taking charity, that's not something I do. There are ways to help quickly move them into a more positive attitude about taking resources that we can share with you. So if you've implemented screening, as I said, one of the things we find very frequently is that there's a strong desire to do more. And there are so many options. It depends on what there's interest in your community, in your specific clinic, and what you think is a good fit for the needs of your patients. The Oregon Food Bank and many of our partners around the state offer cooking and smart shopping classes, gardening classes. We've helped people build gardens on their hospital grounds. We've worked with folks to implement pantries in their clinics or their hospital. We have diabetes education programs that are linked to pantries with incentives of extra produce. You're going to hear about a Veggie RX program that provides vouchers for additional produce for the food insecure or maybe other targeted groups like food insecure diabetics. But again, this kind of screening gives you that ability to target. You don't want to waste your minimal resources on people that can afford to eat healthy on their own. So you screen to the food insecure, and then you may develop a target group like diabetics or pregnant women or, you know, obese kids. That's your clinic's job to decide your target population for any kind of deeper intervention that we would be glad to partner with you on. In some communities, they're having county-wide convenings that bring together human services folks and healthcare staff to look at social determinant issues in their community, prioritize and develop game plans on how to address them together. There are so many new funding possibilities for these kinds of interventions because of the large number of community benefit funds that have been freed up due to reduced charity care. There are CCO incentive fund grants. There are insurers that provide funding for new projects. Think about your big suppliers, your big companies, the EHR, the medical equipment companies. Some clinics have incorporated things into their global budget, and as we move forward, we hope more and more there will be easy access to the flex funds via Medicaid billing. I know that some places, sources or programs like cooking classes, because they're done in a group, are being paid for as a group visit by Medicaid billing. So there just are lots of options, and we're very eager to work with you on identifying some of those. This is my contact information. Yeah.
This is Brian. I feel like the 500-pound gorilla in the room, or the elephant in the corner, or whichever animal it is Tuesday's election. And I'm just curious. I know it's early, but I'm wondering if there are conversations about how much, if at all, any of this stuff gets changed, and if we need to focus our targets a little bit in case some of this funding goes away after the waiver.
Right. I think nobody knows what's coming. You know, they've promised they're getting rid of Obamacare. What does that really mean? They've also promised that they're putting something in its place. So we don't know what that'll be. My anticipation and the gossip I hear is that CMS is going to rush through our waiver so that it gets approved and in place before tragedy happens, and so we at least have a little bit of breathing room there and some precedence about using it. But it's very unknown.
I want to jump in and this is Victoria from OPCA, and we've been looking at this from a policy perspective, and I think that there are two areas where I think that we can draw hope, which is that first, like our speaker last month talked about, sometimes social determinants of health interventions are seen as supportive of the bottom line of a health system or a health insurer. Those insurers are still going to want to provide that. It's financially sound for them to continue those programs. The second thing is that there are some other Oregon-specific possible solutions to at least find money to fill in whatever gaps do happen. There are several conversations that are happening on that with at the governor's level in the Oregon State Legislature to look for other pots of money, because for us it's not a problem just because of Trump, it's also a problem because of Measure 97. So we're not the only people who are concerned. People who have much more money, time, and power are also concerned about this and want to see a change. So I'm pretty hopeful about that. And we do have to move on to Brooke, so if there's any last questions, jump on in.
Sorry, I'll just make one quick follow-up. I am looking at starting to try and work on demonstrating some financial benefits from social determinants work. If anyone else is interested, I'd love to have an ongoing conversation about what sort of methods and outcomes we ought to be looking at.
And Brian, I'll say, and maybe share with others as well, that Brian put forth the request for OPCA to be looking at, and Lynn just shared some resources as well, some ideas around funding this work. So Brian, I now since have gotten some feedback on that, and we'll be connecting with you, and I'm happy to brainstorm with others as well.
And Brian, one person, you and I can talk about this offline, that I would connect you with is Paula Carter at PSU. Is the one who recently published the early evaluation of the Housing with Services project that is showing financial rewards from bringing social determinants work to Section 8 housing. And she's going to continue that, and I think is working with others to try and build exactly that financing model that shows that social determinants work pays off.
So with that,
Hi, this is Lynn. I just have a quick comment about that.
yes.
So I just think that financially, I think it's great to be reimbursed for these services, but I think we just kind of have to keep moving forward.
Could you speak up a little bit? You're having some interference.
I think that it's great to have the financial reimbursement. I also think that we need to stay positive on our end and keep providing these resources and these connections for our patients regardless. I feel like that is going to be really, really, really important moving forward.
We agree completely. For those of you that couldn't hear, I think what I heard was that it's really important, especially during these times and circumstances, for us to continue to support our patients and those that we serve with resources in these areas. And we're completely on the same page, and I think this work becomes more important than ever given the context we're in. So thank you. Okay, so we're now going to switch to our presentation from Brooke Nicholls from One Community Health. And again, if you all have any additional questions, we will hopefully have a couple moments at the end, and feel free to type them into the chat as well.
All right, good morning, everybody. My name is Brooke Nicholls, and I'm a family nurse practitioner at One Community Health. And then I also supervise a lot of our community health worker programs, which includes our work with food insecurity screening and the VeggieRx program. So I just wanted to start off with this quote I found to be pretty inspiring. I won't read it out loud, but let you guys read it. Okay, so these are the main topics that I'm going to cover today, and again, as with Lynn, if you have any questions throughout the presentation, please jump in and feel free to interrupt and ask a question. So I'm going to talk a little bit about the timeline of identifying food insecurity as a priority in the Columbia Gorge area, and then some of the interventions that were created as a result. And then I'll go into a little bit more detail about screening at One Community Health, knowing that many of you are hoping to implement something similar or are already in the process of doing that, and kind of share what's worked well for us and what our challenges have been. And then we'll look at a little bit about the efficacy of the VeggieRx program, some research that's been done, and then some data that we're in the process of collecting. And we'll talk about our key partners. I think one of the main things that's been eye-opening to me is a clinic cannot do this work alone, and then looking at some of the community partners who have really helped us champion work in the Gorge. Then I'll talk a little bit about what's next in the Gorge in our area, what we're focusing on for really broadening our food insecurity approach, and then an award that we recently received. Okay, I apologize. There are a lot of words on this slide. But basically what I'm trying to highlight here is the process that we use in the Gorge, working closely with the CCO to identify food insecurity as a high priority. So back in December 2013, our local health council, through a community health assessment survey, identified food insecurity as a high priority of the community. So it was identified by community members as a high priority, and then as a result, over the course of the fall of 2014, going into the spring of 2015, we had a steering committee that was made up of folks from our community advisory council and then other local community members who expressed an interest in being a part of this work. They came together, created an additional community survey, and polled people directly on their issues, barriers in accessing food. And the results of that more in-depth survey were absolutely stunning and just incredibly shocking in a community like the Gorge that has so much agricultural productivity, that there are still so many people struggling with access to food. We're certainly not a food desert by any means, yet much of the food is clearly being funneled either into other communities or into a select few. So 1 in 3 people in the Columbia Gorge worry about running out of food, and 1 in 5 actually do run out of food. So that steering committee continued to work together and identify different approaches for tackling food insecurity, and that included the proposal to start a veggie prescription program. And Gorge Grown Food Network is the organization that was the brainchild behind that program. One thing that I found really interesting is when the survey results came out, we found that even those who were already enrolled in WIC or SNAP, our school lunch program, still reported really high rates of food insecurity, so it was clear to us that there were additional interventions that were needed. Okay, so now here's the timeline kind of the intervention itself, or interventions rather. So in fall 2014, as a result of having this new information and understanding that food insecurity is a priority of the community, several clinics and health centers agreed to start screening for food insecurity, and we used the 2 validated questions. The health department, the Hood River County Health Department, was, I believe, the first organization, and then one community health where I work, we were the second. And I'll talk a little bit about the flow of what our food insecurity screening looks like. And we started with a small population, just with pregnant moms, and the health department as well was working with WIC patients, so pregnant moms and then young children under 5 were our first 2 populations. And once we kind of got the workflow down, then we expanded it. So let's see, in January we had the program, the pilot underway, and our process was that anyone who screened positive was referred to a community health worker to discuss nutrition, local resources, et cetera. Our clinic.
May I ask a quick question?
Certainly. Go ahead.
Did you do a paper screening or an interview screening?
A combination of both. So we had paper screenings that patients were given, but the community health workers who met with patients, with pregnant moms, we have community health workers that do prenatal care, and they would ask the questions in an interview format during OB initial intakes and then once during the postpartum period.
Thank you.
So yeah, of course, and I'll talk more about that in a minute as to like which works better and why. So yeah, then in summer of 2015, that's when Gorge Grown really developed and launched the VeggieRx program, and we became one of 4 distribution sites for the veggie vouchers. And at that time, the vouchers were redeemable at all of the Gorge Grown Food Network farmers markets in the Gorge. So that was added to our intervention. Prior to VeggieRx, our intervention as a clinic when someone screened positive was the referral to the community health worker who really helped connect that patient with local resources, make sure that they had access to nutrition education if they desired that, et cetera, et cetera. And then once the VeggieRx program was launched, we were able to add that as an additional intervention. Then, yeah, moving into the fall, we were ready to expand food insecurity screening to all patients. And I'll talk a little bit about our workflow on the next slide, but just to kind of give you an idea in a nutshell as to how we aim to target all patients. We do it with every health maintenance exam. Every time an adult is due for their SBIRT screening, we attach it in a written format to that. Anytime a kid or a teenager is due for a well-child check or a teen screen, then it is attached to the MCHAT or the ASQ. And then we kind of have an additional focus on prenatal patients and diabetic patients because we have a community health worker who meets with all of those patients prior to their visit with their provider. So when they come in for routine prenatal visits or routine diabetic follow-ups, then they get an additional screening verbally from their community health worker, with the rationale being that we want to screen everyone, but we are placing a particular focus on those 2 vulnerable populations. Redemption sites also expanded about the same time in the fall of 2015. We added, or Gorge Grown rather, added some additional community sites and grocers, farm stands, so that people could redeem the vouchers throughout the year when the farmers markets are not open. And then One Community Health also added an additional intervention by partnering with OSU Extension to offer monthly community meals and SNAP Ed classes. And those have been held at our fish food bank in Hood River, and then at One Community Health we have a teaching kitchen and at our health center in the Dalles. So, and we've continued to do that. Just had a class last night, and that is co-facilitated with a SNAP Ed educator from OSU, as well as one of our bilingual community health workers. They co-facilitate those classes. And then in January of 2016, there was a little bit of a crisis with the VeggieRx program because the redemption rates over the holidays really skyrocketed. And up until that time, Gorge Grown had been able to fund the program through their initial grant dollars. But with redemption rates just skyrocketing, they did not budget for it and had to put the program temporarily on hold. They were a very generous anonymous donor bailed them out, but at that time we recognized as a community that we needed to really expand and look for other ways to fund this program in order to make it more sustainable long term. Our board at One Community Health decided to self-fund $3,000 a month of veggie vouchers for our own program so that we could offset the cost and that Gorge Grown could focus on funding for other organizations or health centers that didn't have a general budget. One Community Health being an FQHC, we have a large general budget from HRSA, and so we pulled funding right out of that and agreed at least for 1 year to fund $3,000 a month. So we're in the middle of that funding right now. And
that's wonderful.
Yeah, it is. It was one of those moments where I was like, wow, I'm really proud to work here. And we were, Paul Lindbergh just told me last night, we were the first and only, well, not the only now, but we were the first health center in the country to self-fund a veggie prescription program.
Well, and inspire the other one.
And then, yeah, so we have one other clinic in our area that is now funding theirs, and yeah, we certainly get inspired them. And actually, let me skip forward. I'll come back to that slide, but I think this really speaks to why the board decided to support that. Our mission is advancing health and social justice for all members of our community, and I think the board stands behind that mission and recognizes that hunger is an issue of justice. So it speaks a lot to me, and I think to most of our providers, that we put our money where our words are. Okay, and I go back to the flow of food insecurity screening at OCH. This is what it looks like. So if a patient comes in for any of those types of exams that you see, either a medical assistant or a community health worker screens that patient. They receive paperwork often when they're in the lobby, and the food insecurity is attached. It's on two questions on a sheet of paper attached to the ASQ, SBIRT, or MCHAT if the patient is due for one of those annual screenings. If they are not due for one of those annual screenings, but they are a diabetic patient or a pregnant patient, then they have a brief visit. We call them a pre-PCP visit, but they have those visits with a community health worker, and it's just a 15 to 20-minute check-in. For our diabetic patients, the community health workers do several screenings. They ask about depression, they ask about food insecurity, they ask about oral health, medication compliance, lifestyle, all kinds of things. And then the provider has that information before he or she even goes into the room. And then similarly with our prenatal patients, they ask a lot of questions about safety at home, domestic violence, depression, again, food insecurity, dental visits. So they ask all of those questions. And I think this really reflects on one of the points that Lynn brought up, that it empowers providers. If you know that your patient has food insecurity before you even go into the room, then it can really impact your treatment plan and the conversation that you have with your patient. So we have found that to be a good model, that the medical assistant or the community health worker screens the patient before the visit. One of the challenges associated with that is just time, and then medical assistants already have a lot on their plate, so we have gotten some feedback from medical assistants that it's hard. It's one additional thing to ask. There's already so many surveys and so many questions going around. But I do think that overall, medical assistants feel like this is a worthwhile screening. It's something that we actually have an intervention for. So despite that increased burden on them, the overwhelming sense that I've gotten from medical assistants is that they value the screening despite the added work. If the screening is positive, the patient's offered a veggie voucher and a referral. It's an internal referral in EPIC for food insecurity. The vouchers are given to the patient then either immediately or at the end of the visit and recorded in the EMR as well as on a written log for tracking purposes. And the referrals that are generated go to one community health worker in our clinic who is trained in nutrition and local resources, and she is the community health worker who co-facilitates those monthly classes. So she reaches out to the patient personally and offers a one-on-one visit, either a home visit or in-clinic visit, if they would like to talk a little bit more about nutrition education or need some assistance in enrolling in WIC or SNAP. And then she also invites them to that monthly class. Certainly.
Oh, I'm sorry. Is there a way that you're tracking whether screening happens?
Yes. Yeah, so internally our IT department tracks the number of well child checks, health maintenance exams, prenatal visits, and diabetic visits, and then he tracks of those how many patients were screened, how many screened positive, and then how many were referred.
Okay. And that's in the written log or in the
it's in the EMR?
Okay.
In the EHR.
Can we connect with you later about that workflow?
Certainly,
Okay,
yeah. Yeah, and then I review that in theory. I review it monthly. It usually happens more like every 2 or 3 months, just time-wise. so much. Okay, so yeah, any questions at all about our workflow for screening? Okay, well, if anything comes up, then let me know. Okay, and then a lot of folks, including the CCO, have asked about, what are you tracking? How effective is this program? And to date, the only actual research rigorous research that's been done is this Photo Voice project, and it was done by Providence Core Group. It's a qualitative data measure. Do you want me to time-wise?
So we're coming down to the last few minutes. Can I ask folks, we can skip some things, but also if you don't want to skip anything, could you speak up now? And we can try to,
I can send out the entire Photo Voice.
Okay.
It's a 3-page PDF, so I can just send that out.
Okay. Also, but if there are folks who are able to stay for another 5 minutes, that sounds like maybe a no.
I can.
Why don't we do this? Why don't we can send out the Photo Voice resource, but I do want you to get to whatever other material you have, so okay. We'll just scoot through the ending quickly, but let's use this time for you to finish sharing.
Okay. Perfect. Yes, I'll send out the Photo Voice project, but in a 2-second nutshell, it was a series of focus groups with VeggieRx recipients that collected a bunch of really promising qualitative data. And then really talked a lot about fundraising, and I don't have a lot of additional information to add. Yeah, so I think she covered that pretty well. Data collection barriers, this has been, it's been a bit of an issue for us to look at how to collect data on how many patients actually redeemed their vouchers, simply because of HIPAA. We don't have an easy way to share data with Gorge Grown Food Network or the redemption site. So we are all collecting aggregate data, but it's not linked to individual patients. But we do have a work group coming up to look at how can we internally look at the pre and post biometric measures and qualitative data for our patients so that we can determine whether or not it is something that One Community Health will continue to fund. I think my personal stance, though, is do we really need to prove that vegetables, whole fruits and vegetables are good for people? Is this something that, is it worth investing money and researching whether or not it has a positive impact on health when it's so clear to any healthcare provider that giving someone whole fruits and vegetables is nothing but a good thing? Let's see, you only have 10 minutes remaining on your battery on this computer. Okay, so super quickly, I alluded to this earlier, but partners are absolutely an integral part to making this a success, and Gorge Grown Food Network was the brainchild of VeggieRx and has continued to be just such an advocate for finding ongoing funding and whatnot. OSU Extension was a great partner as well.
And Brooke, I just wanted to call out, sorry to interrupt you, but I think this is a really key part because we're inviting our other clinics to think about as they move forward with this work, how they can partner with their CCO and or other community organizations.
Okay.
So I just wanted to call that out because I think it's a really important element as folks are thinking about mapping this work.
Yeah, absolutely. And our CCO has been incredibly involved. All of the people that you see on this slide, all of the key partners have representation on the CCO through our CAC, our Community Advisory Council. So they've been very much a part of the conversation and sharing ideas and how different organizations can be involved. So our CAC and our clinical advisory panel have also been a part of the conversation. We've presented at both of those groups and given an opportunity for feedback and also requested that both the CAC and the CAP write letters of support when applying for grant funding. Gorge Grown Food Network did that. And then when it comes to like community benefit dollars or funding that the CAC and the CAP have, we've asked for what would you like to see in this program in order to support allotting some of that funding to its continuation. Let's see. So kind of what's next for us? One Community Health we have that work group coming up to evaluate the financial sustainability for ongoing. We have indefinite funding as far as we know through OSU Extension to continue offering the SNAP Ed program. And then Gorge Grown Food Network has applied for some additional funding with the support of the CAC and the CAP to look at targeting specific populations and expanding distribution sites again to WIC and the health department and not just One Community Health and the one other clinic, Columbia Gorge Family Medicine. And let's see, I wanted to, so this is only 30 seconds, but because of this work and some other work that's being done in the Columbia Gorge, we were one of 7 clinics around the country, or 7 regions rather, not clinics, 7 regions around the country that was awarded the Culture of Health Prize from the Robert Wood Johnson Foundation. And this was 220 communities applied, and the Gorge was one of the 7 selected. So it was a huge deal. And I think this is Sarah Sullivan pictured here from Gorge Grown Food Network. So she is the one that really came up with the veggie prescription program idea. And Brian, I know you, I sat with you when you were out visiting, so, and I know you're close with Sarah as well. So just want to show this super quick video that highlights the VeggieRx program for the Culture Health Prize. Oh, is that, no, that's not the right one. This right here.
On the so you move your mouse over all the way to the right. And you can see it show up over there.
You want to help?
Yeah. Little play button in the middle?
Yeah.
Aha. Okay.
This is very disorienting.
Okay.
In the mirror? Yeah. Yeah. I'm scared about volume again.
Oh, yeah.
Can you guys hear it at all?
So,
No.
I'm actually,
Okay.
yeah, sorry about that. I think we're having some volume issues on the videos, so we will send this video out along with Lynn's video in follow-up so that you guys can watch both of those. Sorry about that.
Yeah, and I've got a couple other videos as well.
Thank you, Brooke, and so sorry to rush you there at the end. I do want to use our last moment if people, well, we're beyond the last moment, but if people do have any questions, I think we can take those at this point. Really quickly, before we do that, I want to call out that as you guys know, our next webinar will be on December 9th, and I'm really excited for that session. We're going to be working with our Quality Improvement Initiatives Coordinator, Akira, here at OPCA to engage in the pilot/PDSA planning process for the work that we'll be doing. We'll all be taking on around food insecurity screening and intervention. So I will be reaching out to you in follow-up to this webinar with some specific planning questions to really help prep us for that session and the work that we'll be doing together. And as you guys have seen in previous emails, here's kind of loosely what we're wanting you to be thinking about in terms of prepping for that work. So looking at the work that you're currently doing potentially around food insecurity and whether or not you want to expand upon those current efforts or try something new completely. And then also, as I called out earlier, thinking about with whom you may be currently partnering or whom you might like to partner with in your community to take on this work. And I think that Brooke's example and sharing is a really good example of what that can look like successfully and how a clinic can really make their work stronger by working with the CCO and other community-based organizations to further efforts. So with that, I want to, first of all, thank both of our presenters, Lynn and Brooke. Thank you guys so much. And then I also want to open it up for our audience members if you guys do have any last-minute questions, either for Victoria and I or for our presenters.
Hi, this is Denise at Reinhardt. Can you hear me?
Hi, Denise. Yes.
Hello. Yes. So I just wanted to check for the Oregon Food Bank slideshow. You had said that you can do that by county, like what all the local resources are. Is that correct?
Yes, actually, you're in Tillamook County, right?
Yes.
I have that resource list available.
Great. If I could get that emailed, I would really appreciate it.
Yeah, and we actually, I actually sent those out prior to this webinar. So Denise, I'll make sure that you are on that list if you haven't already received it, and we'll resend those out because Lynn very graciously put together those community resource lists for each of the counties in which clinics are represented in this Learning Collaborative.
Do you have translations? I don't know what that's
you did send me translations, so I can send both the English and Spanish language versions of those resource lists.
That would be great, and I may have overlooked it or didn't get it, but I'm not sure. If you could resend it, I'd appreciate it.
Yep, no problem. Happy to resend.
Thank you.
Any other questions from folks?
Question. This is Lori at OPCA. I'm curious who the CCO isn't jumping in to fill that $36,000 VeggieRx gap that you guys are self-funding.
So we have tried to be creative to look at how the CCO would specifically fund that. I think there are a lot of competing priorities, a lot of competing concerns.
For the CCO?
Yeah, for the CCO. And like there are, like we have a 12-week health and nutrition education class that we're also hoping to fund in the community. And there's just a lot of other competing priorities. And I think honestly, one of the things that they have wanted to see, the CAP especially, has been data. Like they want to see pre and post biometric measures.
More proof.
Exactly. They're like, yeah, it sounds great, but is it actually making an impact? And if we are going to have some pressure from the state to see better numbers, like what's truly going to impact chronic disease management, obesity, and so
one of the challenges when the board VeggieRx program was set up was originally all about addressing food insecurity, and there were no narrower target populations within that broad population, and so that it was hard to collect data about diabetes because it wasn't you've been referred because you're a food insecure diabetic and therefore we'll track these medical markers. It was you're food insecure, here you go. And so one of the things I've worked a lot with Gorge Grown on trying to come up with a viable way to get this funded, and it has to be, and there's a philosophical tug of war going on within the Gorge about this issue. We believe that, you know, food justice and everybody who's food insecure should get a voucher versus we got to be practical and target a specific group and then track medical indicators and provide that data. So that push-pull is still in play.
Yeah, it's still happening within our clinic. And then an enrollment period, too, is another thing, because right now there's an indefinite amount of time. Somebody can screen positive and receive vouchers forever if they continue to screen positive. Right. And it's and there's no, in order to qualify for the program, the criteria is simply answering yes to either of those two questions, sometimes or
and I do want to emphasize to anybody on the phone that I'm working with over 10 different veggie voucher type programs around the state, and they're all different, and some of them are quite narrowly defined and have, you know, a lower price tag because they're really limited, and they also are able to provide a bit more clinical evidence of impact versus the social justice model that tries to really be a social determinant and preventive approach that the Gorge has used.
I just want to, this is Brian, I want to interject one thing. I've had conversations with a couple of CCOs and some targets that they're interested in. I totally agree about this, this dichotomy between screening everyone and showing financial benefit. I think they can exist in parallel. I think that we can continue to do the ongoing social justice work, especially if we're able to do some long-term measurements. In the short term, it will add some power if we can show some financial benefit, and a couple of targets that have been highlighted are the high utilization patients. So if we can impact ER rates, if we can impact hospital readmission rates, if we can impact medication adherence, there's some shorter-term targets that I think will go a long way to really getting some proof of financial benefit. You know, I think that the numbers that we now have across the state could make some of those things possible where, you know, smaller sample size just wouldn't be able to do that on a short term.
And I think that that's one reason that moving, this is Victoria, toward a PIP and some kind of screening and tracking, if we can associate our screening rates and call out, you know, we're screening these certain subpopulations, and we also see reduced rates of ER utilization, we would be able to obtain that even without capturing consistent biometric data. And that would be one way to kind of circumvent this very costly kind of patient-centric VeggieRx program and still have something that is a little bit more like family-focused and social justice-y without needing to also capture biometric data every 4 to 6 weeks to make sure that we're making some change.
So I'm aware of time here. We're definitely over. I want to check in with other attendee members and see if anyone else has any other questions for our, and again, of course, totally can follow up via email as well, but while we have our two presenters here, are there any other questions that you guys have for Lynn and or Brooke? Okay, well, we will definitely send out some of these resources and follow up. I heard a request for the resources that Lynn shared. We'll also share both of the videos that, again, we apologize did not play correctly. And we'll also, as usual, send out a link to the recorded webinar for you and any other staff you work with that are interested in seeing the conversation. And lastly, as I mentioned, we will also be in contact about starting to prepare for our pilot planning session coming up in December. So with that, I will say thanks again to our folks, our presenters today, and thank you to our attendees for joining us, and we will be in contact soon.
Thank you, everyone.
Thanks.
Thank you.
I can't.
Thanks, guys.
Okay, there it is.